Morning to everybody. My name is Michele Vignali and I work in the University of Milan. And the topic we are going to discuss today is the endometrioma and fertility preservation. We know that endometriosis affects up to 10% of women in reproductive age, and in 30 to 50% of these cases, patients with endometriosis face infertility. And this is a condition that can reduce fecundity from 15%, which is we found in the normal population, up to 2% to 5% per month in those women with endometriosis. But why endometriosis is associated to the infertility? There are many factors that can influence this condition, from the distortion of the anatomy of the pelvis, the coexistence of adenomyosis, the presence of an inflammatory environment that can inhibit sperm motility, tubal motility, and can negatively impact on conception and embryo development. Or we know that the eutopic endometrium can be different in terms of receptors for estrogen or for progesterone. But one of the main problems that it is associated with infertility in patients with endometriosis is previous ovarian surgery and consequently a reduction of the ovarian reserve. We do know that the most common location of endometriosis is the ovary, and ovarian endometriomas occur in 17 to 44% of these patients. When we talk about endometrioma, we must not say that we are speaking about a cyst, a real cyst, but almost a pseudocyst, because this endometrioma, the cysts are formed by an exovarian hematoma that is surrounded by duplicated ovarian parenchyma. And this is very important when we do surgery for endometriomas, because accidentally, whenever we operate on an endometrioma, we remove accidentally a part of the cortex, and so we can induce a reduction of the follicle numbers and a reduction of the ovarian reserve. In 2008, Cochrane review stated that excisional surgery is better than a drainage and ablation when we operated on an endometrioma, in terms of more favorable outcome, in terms of recurrence of endometrioma, recurrence of symptoms, and spontaneous pregnancy, so that now we consider excisional surgery the gold standard surgical approach. But it is true that since a long time, this is a paper that was published in 2003, we know that excisional surgery for endometrioma can reduce significantly the ovarian reserve. In 2006, we published a very interesting paper in which we demonstrated in patients with bilateral endometrioma, patients that have been operated on for bilateral endometriomas, 2.4% of premature ovarian failure, which is almost double that we found in general population. And the same results were demonstrated by another group of Milan regarding the unilateral endometriomas, demonstrating an ovarian damage of 13% of patients. So there is a dangerous relation between surgery for ovarian endometrioma and ovarian reserve. And this was demonstrated in many papers, and finally in 2012, two important meta-analyses were published in which the authors stated that ovarian surgery can damage ovarian reserve up to 40% when we consider anti-mullerian hormone concentration as an indicator of ovarian reserve. But anyway, the long-term effect of the surgical treatment on serum AMH remains to be investigated, because there are many papers. One of these papers we published one of these papers in 2015, and in which we demonstrated that measuring the anti-mullerian hormone before surgery at 1, 3, 6, and 12 months after surgery, we found a complete recovery of preoperative AMH values at 12 months postoperatively. And the same results were demonstrated by another group in Cleveland, by a group of Tommaso Falcone, in which after 6 months they found a difference that was no more significant after 6 months, always in terms of a measurement of AMH. Probably there are many factors that contribute to the reduction of the ovarian reserve. There are different characteristics of the ovarian endometrioma, and maybe the bigger one, larger than 7 centimeters, the bilateral ones, and the severe endometriosis can have worse results in terms of reduction of the ovarian reserve, but maybe small cysts, unilateral cysts, sometimes can really have fully recover of AMH. Some authors stated that suture can be protective in terms of reduction, lower reduction of the ovarian reserve, but some other authors, like this Italian group, show that the reduction of AMH or FSH levels are independent from the method used to obtain hemostasis, whether it is suturing or using bipolar. So when we operated on for an endometrioma, what is the best procedure? It is important always to find the correct plane and to respect the hilus, to rinse a lot, to coagulate the less, and to be very careful, very patient, because it is true that this is a very easy surgery, but it is important to do it in the best way. Some people or some authors proposed another type of another procedure, which consisted in the excision of 90% of the cyst and leaving 1% of the cyst, the part near the hilus, which is the most vascularizated, and the part in which we found the highest number of follicles, and this little part of the cyst should be coagulated. But we did a multi-center randomized control study in Italy, and we demonstrated that the stripping technique should still consider the gold standard approach for the surgical treatment of endometriomas. A very interesting paper that was published last year on the Human Reproduction Update concerning the impact of unilateral versus bilateral ovarian endometriotic cystectomy on ovarian reserve. And this was a systematic review and a meta-analysis. The authors remarked the important damage that we found after surgery for endometrioma, and up to 40% in unilateral endometriomas, and 60%, almost 60% in bilateral endometriomas. But the important conclusion of these authors, that was that conservative treatment should be counseled as the first line of treatment until the patient's reproductive aspirations are realized. So that surgery must be postponed until family planning is complete. Was a very important message that came from this meta-analysis. And on the other side, what we must think about, what we have to ask to ourselves, okay, if it is not good to operate on endometriomas for the patient, so the patient must choose conservative treatment and wait to be operated on until the family planning is complete. But what we can do, what will happen to the ovary if we don't, with the ovary with an endometrioma, if we don't operate on it? Actually, there are several papers that have demonstrated that when an ovary has an endometrioma, the ovarian reserve is damaged anyway. Since this paper, 1993, by an Italian group in which the authors thought that destruction of the cyst could impair the ovarian reserve, but there are many papers that have shown that all the follicles of the tissue around the endometrioma has a higher percentage of fibrosis and a reduction in the number of follicles. And last, this nice paper published in 2003 from the group, in another group in Milan, showed that the contents of the cyst with reactive oxygen species and iron can damage the tissue around and around the cyst, and creating a fibrosis and determining a reduction in the number of follicles. So it appears that the endometrioma per se may damage the ovarian reserve, and this could progress along with development and growth of the endometrioma. So it is true that if we operate it on, we can have a reduction in the ovarian reserve, but it is even true if we leave the ovary with an endometrioma, this could lead to a reduction of the ovarian reserve. And as in this paper, Professor Somigliana and his group showed that the ovary that has an endometrioma, when compared to the other ovary, has a lower rate of ovulation, and this obviously can lead to a reduction in the fecundity. Last, another important paper was published last year, 2 years ago, but no, at the end of 2018, from a Turkish group, in which they measured the AMH in patients with endometrioma and in patients without endometrioma in 6 months. And what they showed was that women with endometrioma experienced a progressive decline in serum AMH levels faster than in the healthy woman. And this reduction, as you can see, was very high because it was around 26.4% compared to 7.4% of the control group. So if we have to choose to underline one of the main concept that I think that it's very important is that the first preservation in case of ovarian endometrioma is to avoid useless surgical procedures. So first of all, non nocere. But what the guidelines say, what the association, the main association, tell us to do if we cannot operate on the ovaries with endometrioma, not to reduce the ovarian reserve, but otherwise, if we have an ovary with endometrioma, we will observe a reduction in the reserve. So what we have to do? The EFRE guidelines that have been published in the first trimester of 2014 tell us that in patients, in fertile patient with endometrioma, first of all, we have to choose excision of endometrioma and not drainage and coagulations. But if we want to, if we operated on these patients, we will see an increase in spontaneous pregnancy rates. So if we are not going to submit our patients to ART, to ART, but in patients with endometriosis, severe endometriosis with endometrioma, is infertile, we can operate on them if the patients are symptomatic to increase spontaneous pregnancy rates. Otherwise, if we have patients that are undergoing ART procedure, there is evidence type A that patients with endometrioma larger than 3 centimeters will not gain any advantages to be operated on before ART. The only advantages, and this is a good practice point, that this patient can gain is to improve endometriosis-associated pain and a better accessibility to the follicles. Another question that EFRE answered to is, medical assisted reproduction effective for infertility associated with endometriosis? The recommendation is to use ART in this infertile patient with endometriosis, and because no recurrence rates, not worsening of the recurrence rate have been observed in those patients that are undergo ART and ovarian stimulation. But a very interesting meta-analysis was published the year after the publication of EFRE guidelines. This is a very interesting meta-analysis that was published on the Human Reproduction Update. And the title was The Impact of Endometrioma on IVF ICSI Outcomes, a Systematic Review and Meta-Analysis. What the authors said, and the same concept were expressed in another meta-analysis that was published the same year, is that when we compare women with endometrioma, and women without endometrioma, we observe a similar live birth rate, a similar cumulative pregnancy rate, and a similar miscarriage rate. Even if in patients with endometrioma, we can observe lower in number of oocytes retrieved, higher FSH dosage for ovarian stimulation, and an AFC reduced. Maybe because we have, for the things that I showed you before, even in patients with endometrioma, the ovarian reserve reduce and tend to reduce with time. The patients with endometrioma are more at risk of cycle cancellation. So they need to be counseled about this. And another concept that have already been expressed is that surgery seems not to influence the live birth rate in this patient, but we know, I showed you how surgery can be detrimental for the ovarian reserve. And 4 years later, this meta-analysis was published, remarking the concepts that I already showed you, that women with endometriosis-related infertility have similar cycle outcomes to other patients going through ART. And pre-cycle surgical management of endometrioma does not appear to be beneficial, except for the reduction of symptoms. There are no strict guidelines in terms of which patient with endometrioma should be operated on, but surely patients that are resistant to medical therapy and are very symptomatic should be operated on anyway. Endometriomas should not be resected to improve ART outcome. It is a concept that we have already seen. But so what we can do? What we can do when we have an endometrioma and we don't want our patient to have a reduction in terms of ovarian reserve. In this recent years, we have published many papers, and there is a lot of literature about that, but we published, especially in Italy, several articles about the effect of Digest on the endometrioma. We have seen that medical therapy with the Digest 2 milligrams every day can reduce the volume of the cyst up to 70, 79, 80%. And this is very important because a patient with a large cyst can reach a little cyst. And as I showed you before, if you remember, larger cysts are those that are at more risk of not recovering the ovarian reserve after surgery. And it is sure that if we reach a reasonable diameter of the cyst, the patient, and obviously with Digest, even the symptoms will be improved in this patient. It is obvious that this patient won't need a surgery, and this is very important because surgery is the major enemy that we have for fertility preservation. And in another paper that we published last year with the group of Rome, the Professor Muzzi is always with the therapy, the medical therapy. What we saw is that these patients with endometrioma that undergo medical therapy of 2 milligrams a day with the Digest will not only reach a reduction in the volume up to 79% and a reduction in the pain symptoms, but even the AFC, the antral follicle count, will be increased. So even the ovarian reserve will be preserved. So our conclusion my conclusion is that it's true that patients with endometriosis will face infertility in 30–50% of cases, and they will show a reduction in the fecundity rate up to 2 to 5%. And there are many factors that can contribute to this reduction, but obviously this condition. But obviously, one of the most important factors that can affect ovarian reserve, that can affect fertility in those patients, is surgery, because cystectomy can reduce ovarian reserve, even if it is questionable if this condition can persist in long-term follow-up. But we have many data that show that especially for bilateral endometrioma, surgery can be detrimental for the ovarian reserve. So as the meta-analysis published in 2019 said, the conservative management should be adopted until family planning is complete, because this should be our choice. On the other hand, endometrioma per se could impair ovarian reserve, because we have seen for this destruction of the capsule, the content of the cyst can determine fibrosis around the cyst. And so on the other side, we will have the problem of what to do. We have seen what the EFRE guidelines can suggest, but Actually, what we can use, the best thing that we have, the best remedy that we have found is a therapy with Dynergist 2 milligrams a day that can reduce the size of the endometrioma, but on the other side can reduce the reduction of the ovarian reserve. And what we have seen is that we observed an increase in the antral follicle count while decreasing painful symptoms. Finally, it is true that when we want to send this patient to ART, women with endometriosis-related infertility have similar cycle outcomes. It is true that they have lower number of oocytes retreats, but at the end, the results are exactly seem comparable to other patients going through ART. So we don't need to be scared about sending these patients to ART instead of operating them for endometrioma. Endometrioma should not be resected to improve ART outcomes because we know, we have seen, I've shown you the detrimental effect of surgery on ovarian reserve response. And at the end, this does not mean that we will not operate on endometrioma anymore, because patients with endometriomas and painful symptoms that are resistant to surgery, to medical therapy, obviously will benefit from surgery anyway. So I thank you very much. I am